Yeah, good evening, doctors. Welcome to the cardiovascular CBS session. So, CBS session is one of the most important ones. It's basically computer-based session. So, a computer will generate a question, a scenario, and then it will generate a question, and you will have to answer that question. So, I've just kept few important cases of cardiovascular science, which are important from EDIC point of view. So, without wasting much time, we will just start with the class. So, we have a 68-year-old male who presents to the ICU with chest discomfort and shortness of breath. He has a history of hypertension and type 2 diabetes mellitus. Now, this is the question stem. So, basically, what you have is a patient who has come to the ICU with chest discomfort and shortness of breath. So, you see the ECG. This is the ECG that is there. So, can anyone open up their mics and tell me what do you see in the ECG?
Inferior wall ST elevation MI with reciprocal changes in the anterior chest leads.
Okay,
This
so
is suggestive of acute coronary syndrome.
yeah, so basically, when you describe an ECG, you tell that this ECG it looks like a sinus rhythm with ST elevations in lead 2, 3, AVF, along with reciprocal ST depressions in the anterior leads. So, hence the diagnosis is acute inferior wall STEMI. So this is how we reach the diagnosis. Your diagnosis is correct, but you spoke the diagnosis at the first instance. So you explain the ECG first, and then you decipher the diagnosis. Fine. So what would you do if such a patient comes to you in the ER or in the ICU? If this is the patient and this is the ECG, what will you do immediately? What are the two next best steps?
So first we will resuscitate the patient. I will manage the airway, breathing and circulation. I will try to maintain saturation about 95% and taking care of circulation. If the patient is in shock, then vasopressors need to be started. At the same time, I will proceed with percutaneous coronary intervention if my hospital has the facility to do so, or maybe thrombolysis depending on the hospital.
Anything before that?
Dual
So
anti
we all know that PCI has to be done, but there is something that you have to do before that.
aspirin 300 milligram and cloplet
Correct. So
300
we
milligram.
have to give antiplatelets immediately. So it has been seen that when the antiplatelets are given almost instantly, for example, those patients who are either doctors or medicos or know that they have to take aspirin, those patients, when they take aspirin immediately on the onset of chest pain, they do extremely well because it decreases the thrombus load in the coronary arteries. So the first step that you have to do, you have to give them, load them up. That is the loading. Word is loading. That you load them up with aspirin and another antiplatelet agent. So what is that technique known as? This is known as DAPT. That
So
is dual antiplatelet therapy. So you have to start the dual antiplatelet therapy immediately. So when we discuss about DAPT, immediately the next question comes, what DAPT? What two drugs that you will give? So first is aspirin. That is the common one. That is essentially the common one. One, because it can be dissolved. Second, it has the maximum data. So most of the studies that have been done till today, they include another drug with aspirin. So aspirin is a standard. If you don't have the another drug, that is fine, but aspirin is the standard. So you have to give aspirin plus something else. That something else could be clopidogrel, it could be ticagrelor, it could be prasugrel. I was on my phone, but my laptop has just, it has got charged. So if you are okay with it, I can shift to there. If you're okay, we can move there. Sana?
Yes, of course.
Can we do that?
Yeah.
Because then I'll have a pen to work with. Yeah.
Yes, sir, sure, we can. Please.
Okay. Thank you. Bye. So what we have here is, number one, we have ST elevations and we have ST depression, which are reciprocal changes. Fine. So we have arrived to the diagnosis of inferior wall STEMI, which is a type of ACS. So ACS is basically a coronary obstruction that could lead to either transmural infarction or it could lead to subendocardial infarction. Subendocardial infarction is non-STEMI, a complete total occlusion leading to a transmural infarction is STEMI. Of course, in a transmural infarction, we have to be very, very aggressive. But the moment you see ECG changes, the first thing that you have to do is, of course, take care of the ABC. Second, simultaneously, so both are one actually, you have to load the patient up with aspirin. Okay, 300 milligrams. And of course, you have to give another agent, which is either clopidogrel or ticagrelor or prasugrel. So the diagnosis we have is inferior wall MI. And how do you define STEMI? Now, that is another question. So STEMI is ST elevation. Then you need to know what is ST elevation. ST elevation is more than 1 or equal to 1 elevation in more than 2 inferior leads, that is 2-3 AVF, with reciprocal ST depression that we saw. If we are talking of V3 and V4, the ST elevation criteria is different. Okay, in males and females age of 40 and above. So in that case, the criteria to define ST elevation is different, that you need to understand. Okay. So in case, whenever we see RV or basically inferior wall MI, now this inferior wall MI, if I have to draw the coronary circulation here, if I have to draw the coronary circulation here, this is the coronary cusps, this is the left main, this is circumflex, this is the LAD, and this is the diagonal. So this is the RCA coming here. So this is the picture diagram of the heart and on the coronaries. Now, you see clearly that there is inferior wall MI. So this is inferior wall. So this is undergoing a infarction. Now you can actually see that some part of coronary arteries, and there is vessel coming from the circumflex also, which provides the same region. So sometimes it is circumflex. That means the inferior wall MI can be because of RCA or it can be because of a branch of circumflex. But if it is RCA, right coronary artery, it may lead to RVMI. Now, this is nowadays very, very important. Why? Can anyone tell me about RVMI? Why it is important these days? It wasn't so important like few years back, but now it has got attention of everyone. Can anyone tell me why? Any guesses? Because it will be important for your exam.
Conduction blocks are present.
Yeah, that has always been there. Right coronary artery supplying supplying the AV sign block. We all know this. But then IABP is not an option. This is why it is important, because till today, whenever a patient of acute MI was going into shock, cardiogenic refractory cardiogenic shock, or had gone into refractory cardiogenic shock, the next device that we would put was IABP, intra-aortic balloon pump. But now it is, because in RVMI it will not help at all, because the RV is pumping blood into pulmonary artery. We are not putting IABP into pulmonary artery. We are putting IABP into aorta. And aorta is connected to left ventricle. So left ventricle assist device is IABP as small as possible. Then are the bigger ones, impella and all, LVAD. But we do not have a RVAD. So what is the technique that is used to pull out the patient of RVMI from cardiogenic shock? Anyone? This is
It
EDIC
is
level. Yeah, go on.
with volume therapy.
Okay, we have done all of that. The volume therapy we have done. The patient is still continuing in cardiogenic shock. And the diagnosis is RVMI. LV is working absolutely fine. The only therapy that will work there is ECMO, EAS, nothing else. Okay? So if you have a diagnosis of RVMI with cardiogenic shock and you have loaded up the patient with IV fluids and still continues to remain in cardiogenic shock, there is no benefit of marking IABP as the next modality of choice. The next modality of choice will be directly VA. Okay? Yes? So, when do you consider an RV infarct? Do a right-sided ECG. If there is persistent hypotension, the lungs are clear and the JVP. When this is apparent, then you are dealing with an RVMI. So you need to do V789. Is that clear? So plan for PCI or thrombolysis. How do you do that? The PCI has to be done within 90 to 120 minutes, that is up to 2 hours of the first medical contact. If you are not able to do in 120 minutes, then you have to thrombolize the patient. In those cases, the data is same for thrombolysis or PCI. Both of them are beneficial. But the problem is for thrombolysis, you have to go through the checklist of contraindications. Antiplatelet therapy has to be given immediately. 300 milligrams of aspirin has to be chewed. It has to be crushed and dissolved in water and given to the patient. So immediate action. Or you give P2Y12 inhibitor along with, it is not or, it is and you give ticagrelor. This is European favorite now. So even in AHA guidelines now it is ticagrelor. Earlier it was only European guidelines which had ticagrelor in them. Now it is AHA also supporting the same. Or clopidogrel 600 milligrams. Many times people tell me 300 milligrams of clopidogrel, but no, it is 600 milligrams. So ticagrelor 180 and then 90 mg BID, clopidogrel 600, even 300 is fine, but then 75 milligram BID or prasugrel 5 mg. If the PCI is planned and there is no contraindication, that is people less than 75 years of age. So one is that you do your ABC, second is you do give DAPT, third is you plan for PCI if it is less than 120 minutes, thrombolysis if you suspect more than 120 minutes, fourth is anticoagulants. That is also important. If primary PCI is planned, then unfractionated heparin with GP2B3 inhibitor. Although the GP2B3 inhibitor like tirofiban or epfibitide, they are used to decrease the thrombus load, but their role is very, very restricted now, but you should know about them. And if you thrombolize the patient, then of course, unfractionated heparin or enoxaparin, or in whole of the Europe, fondaparinux is the drug of choice. Why? Because once a day dosage. Many guidelines of Europe are because of the state-sponsored treatment, and they always prefer once daily treatment. Then, along with that, you give nitrates. What are the indications of nitrates in patient of ACS? Anyone? What are indicates in ACS or acute MI?
Sir, if persistent
Anyone?
chest pain is there.
Okay, persistent chest pain is there.
And there is no any contraindication like hypotension.
Okay, so for chest pain, we are giving nitrates in MI.
Also helps in reducing preload.
Okay, so what are the indications? Come on, tell me the indications. One indication is patient in pulmonary edema or acute LVF. Second is accelerated hypertension along with MI. Okay, now these are two very important indications. Essentially, we do not give nitrates to a patient who is suffering acute myocardial infarction. Can anyone tell me why? Because of the steal phenomena. See,
Okay.
people keep giving it, but then it is not indicated. If you look at the any algorithm, nitrates are nowhere in the acute coronary syndrome, ACS NT, specifically in STEMI. Why? Because let us say this is the blood vessel and this is occluded here, or and then there are other vessels. So whenever this happens, the nitrates they increase the lumen irrespective. So what happens is the other blood vessels they get preferentially more blood than the involved coronary artery. This is called coronary steal phenomena. So unless the patient is having okay ongoing chest pain, but that is due to MI, so we have to treat MI. Patient in pulmonary edema or patient having accelerated hypertension, only then we give it. When we do not give it, in RVMI or in shock, of course. In right ventricular MI, inferior wall MI, nitrates are contraindicated. Why? They will decrease the preload. And in RVMI or inferior wall MI, it is the preload which is maintaining the circulation. In inferior wall MI, it is a preload determined circulation. Is that okay? So nitrates are given for chest pain if there is no hypotension or there is no RV infarct. Avoid nitrates in RV infarct. Why? Because it is a preload dependent circulation. When the systolic BP is less than 90, you do not give nitrates. When patient has a history of recent phosphodiesterase and the of using these sildenafil and tadalafil for recreational uses is also very common. So you have to take the history that the patient has not taken them. Is that clear? Along with that, you have to give analgesia, IV morphine for ongoing pain, and then monitoring for hypotension and bradycardia. Oxygen only if saturation is less than 90 or in respiratory distress, then you give NIV support also. Beta blockers are given only if their patient does not have heart failure, does not have bradycardia, does not have heart block or hypotension, and you should not give it in RV block. Why? Because in RV infarct, the chances of AV nodal block is high. So if you give beta blocker, the chances the patient lands up into a complete heart block. So assess for RV infarction. Always do a V4R ECG. Manage, avoid nitrates, diuretics, give IV fluids to optimize preload, keep CVP around 15 centimeters, inotropes if hypotensive. And then, of course, once you've taken the patient for primary PCI, the patient needs a continuous ECG monitoring and hemodynamic analysis. Watch for any arrhythmias, reperfusion arrhythmias, blocks, hypotension, and of course, papillary muscle and mitral regurgitation. Have you got this situation clearly? Yes, it is one of the most favored topics. It always begins, cardiovascular station always begins with a STEMI. Anything else that you would like to know? Do you need to know the algorithm of if the patient comes back, goes into heart failure? Do you need to go there? All right. So I have another question for you. Station number 2, chest X-ray. A 60-year-old woman on mechanical ventilation suddenly deteriorates, desaturates, and has increased peak airway pressures. What does the chest X-ray show? Now, don't tell
Right
me the
side.
diagnosis, okay? Give me the finding. So, what do you see on the chest X-ray? So, you see
There is a
right-sided.
hyperlucent right lung field.
Very good. So, there is a hypertranslucence in the right lung field, along with anything else?
Uh,
The
decreased lung markings.
tracheal deviation to left side.
Yes. So, there is a deviation of the trachea to
And
the.
decreased lung markings on that same side.
So, what we have here is.
A case of tension
We,
pneumothorax.
yes. So, this we have pneumothorax along with compression symptoms, compression signs. There is deviation of the trachea to the whole of the left side, defining tension pneumothorax. Okay.
Sir,
So,
but there is no hypotension for that tension. I mean, there should be BP should be.
I have not mentioned the BP anywhere. I have said a 60-year-old woman on mechanical ventilation has suddenly deteriorated, desaturated, and increased peak airway pressure. If I would have to mention, I would say, okay, heart rate is 160, BP is only 60 systolic. I did not mention it, but then that's okay. That's the thing is that this is X-ray station. So once you get the hold of the X-ray, then you can define the things for yourself. Okay. So you see a tension pneumothorax. Now you tell me what is the management of this patient. This patient. Then we would go into the another discussion of it. What would you do immediately?
Needle decompression.
Wonderful. So you would do needle decompression. Where will you do needle decompression?
Second
Where?
intercostal space, mid-clavicular line.
So second intercostal space in mid-clavicular line. Perfect. So the image shows a right-sided hyperlucency with mediastinal shift to the left, giving an impression of right-sided pneumothorax. So what are the immediate management steps? So tension pneumothorax is a life-threatening emergency that requires immediate recognition and immediate intervention. What are the signs? Hypotension, tachycardia, respiratory distress, unilateral absent breath sounds, deviation of the trachea away from the affected side. This is a clinical sign. Distended neck veins and cyanosis or desaturation. So diagnosis is clinical. Do a percussion, you would get the diagnosis. Do not wait for chest X-ray or CT. Be confident. Put the needle in the second intercostal space, mid-clavicular line on the right side. Another is fifth intercostal space, anterior to the mid-axillary line. So the triangle that is formed in the axilla. So here in the mid-axillary line, fifth intercostal space, somewhere here, anterior to the mid-axillary line, you put the needle, especially in the trauma guidelines like the ATLS. You need a large bore cannula, and the technique we all know. Insert above the rib to avoid the neurovascular bundle. Listen for the rush of air confirming decompression. This is temporizing measure only. Definitive management is putting the chest tube or the tube thoracostomy. So put in the chest drain that is put at the fifth intercostal space anterior, mid-axillary line on the right side. Connect to the underwater seal drainage system, confirm air evacuation and lung re-expansion. So the first step is needle decompression. Second step is ICD, that is intercostal drain. Of course, you need to put the patient on high flow oxygen, maybe around 100%. Why? Because then it will cause absorption of the pneumothorax via the non-rebreather mask. Avoid intubating if the patient does not need intubation. If they need intubation for any other reason, then definitely you will need to intubate them. But for tension pneumothorax, putting in a needle and followed by a chest tube is sufficient treatment, and then you just have to wait and watch. Of course, if the patient is hypotensive, give IV fluids and resuscitate the patient. In this situation, this is one of the rare situations where ABC is already in front of you. The airway is not compromised, breathing is troubled, and circulation is collapsing. So that defines tension pneumothorax. That defines and differentiates it from the pneumothorax, I mean spontaneous pneumothorax, which is not amounting to tension. So tension pneumothorax has already the elements of breathing difficulty and cardiovascular collapse. After
Sir, one
stabilization,
question. Uh,
yes.
Sir, is there any difference between pneumothorax and hemothorax or hydrothorax in to choose intercostal space?
No, because these are the safe places where you enter. So, in case of the only thing is that you don't enter into the mid clavicular line for hemothorax or for massive pleural effusion. You don't do that.
Sir, in
The
both cases,
second,
we should choose fifth intercostal space and triangle of safety.
yes, always,
Okay. Okay.
always.
Okay. Thank you.
Okay, yeah, because that is the safest area to enter into the thoracic cavity. Okay. After stabilization, confirm the chest tube position. Always, always, always. Many times students forget mentioning the chest X-ray to be done after chest tube placement. Why? Because sometimes chest tube perforates the pleura and goes into the other pleura or is even lying in the mediastinum. Along with that, it also helps you to ascertain sometimes it's a loculated pneumothorax. Okay, I had a patient who came to me from some other hospital. Patient was of SLE. So this is just a CT that I am showing you. There was this, the heart was placed here, and here there was a pneumo-like situation, and there was an ICD here. And the patient was continuously getting bubbles here, foaming here. So basically, the patient has developed a bronchopulmonary or bronchopleural fistula. So what was the diagnosis? Was the patient had an SLE with large bullae, so large bullae that the doctor of the hospital thought that this is a pneumothorax. He put in the ICD and accidentally actually put that into the bulla. So it was communicating, of course, the bulla is what? Bulla is an alveolar space. So it continued to breathe oxygen, air into it, and the air kept on coming out, and that patient had a very bad time. Eventually survived, but then required VATs and all to suture the perforated pleura and everything, and the lung also required some sutures. So these are few things just for anecdotal experience I'm telling you, not that it will ever come in the exam. That's called a vanishing lung syndrome, just like alpha 1 antitrypsin deficiency. So what happens is the internal structure is all gone and is a large bulla. So large that on an X-ray it looks like pneumothorax only. But only on CT and a very minute looking at it, does the radiologist they report that there is a thin line of pleura outside the air. So that means it's not pneumothorax. Pneumothorax is air outside the pleura. As long as the air is inside the pleura, it is not a pneumothorax, it's a bulla. Is that okay? Just for your reference. All right. Then, of course, you search for the treat for underlying causes, consider ICU admission, and that's it. All right. Now we go on to the third station. So we have a 50-year-old patient with acute kidney injury and is reported to the emergency room with slow heartbeat. That is bradycardia. So this is what you see. Can anyone tell me what you see in the ECG?
Tall T waves are
It's a very
evident in.
interesting ECG.
This might be hyperkalemia with
Okay,
bradycardia.
so tall T waves are evident.
This is not a sinus rhythm. I
Is
can't
it
see.
a sinus bradycardia or it is not? Very good. So
Not
you
a
don't
sinus.
see any P waves, but if you see the last lead, that is the rhythm strip, you see something there. You see there are P wave here, small 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 P wave here. See? So basically, this patient has a complete heart block and total AV dissociation. So this is important. This patient has complete heart block with AV dissociation. And yeah, there are tall T waves. So you have rightly picked up acute kidney injury leading to hyperkalemia. So how will you manage? I yesterday had a patient. Let me see if I have both ECGs with me. Give me a moment. Yesterday I had a patient and we treated that patient before we could get the report of potassium in our hands. Let me just see. Okay. Yeah. Just check out this. This is from yesterday. How do you make it straight? Okay. Yeah. Done. Yeah. Can you see the screen?
Yes, sir.
What do you see?
So this is bundle branch block pattern with tall T waves. Left axis deviation with bradycardia.
The heart rate is 72 here. So it's not a bradycardia. Okay. I have many ECGs for you. Just hold on. This is from today's another patient. Yeah. This is coming. I think it's received. Yeah. Anyone? This is from today. What do you see? Anyone?
Pacemaker spike.
Okay, good. There is a pacemaker spike, but much before that, what? How do you comment on this? So I see a running ECG in the cardiac monitor, which shows no congruence between the P waves and the QRS complexes. So what I see is three P waves. I don't know if I can use the pen here. I don't know. Maybe I can. No, I can't. So, oh, oh, no, I can't. Yeah, I can. Okay, fine. So what you see here is a P wave, a P wave, a P wave, and another P wave, and then a P wave, and then a P wave, a P wave, P wave, another P wave here, a P wave here. So many P waves. This is a excellent case of complete heart block whom we paced, and at this point of time actually we were checking if the patient has got their rhythm back. So we had just put the pacemaker to a bare 30 beats per minute. So what you see is a total AV dysynchrony. Yes. So this is complete heart block due to hyperkalemia. Coming back to the class, so what electrolyte imbalance is most likely? You rightly said hyperkalemia, peak T waves, wide QRS complexes. So what are the immediate steps in the management? Can anyone? Yeah, calcium, fine. Okay, I will write it down. So one is calcium, then
GI drip.
okay, GI drip, then
Sir, first we will manage airway breathing circulation. After that,
oh,
we treat give
Yeah.
anti-hyperkalemic measures and shift patient to for TPI.
Okay. So once ABC is done, we go for IV calcium. I will ask rationale for everything. What is the rationale of giving IV calcium?
The cardiac stabilization.
Membrane stabilizing.
Membrane stabilizing action. But what will it do? Will it reverse whatever problem has been caused by the potassium, or what are the indications for it to be used? Let us say a patient has a potassium of 6.4, a normal sinus rhythm. Patient has come to you with maybe breathing difficulty. Will you give IV calcium?
No, sir.
Why?
Sir, only if ECG changes are there.
Very good. So if the patient has hyperkalemia plus ECG changes, that means cardiotoxicity of hyperkalemia. The calcium is not an antagonist of potassium. No, it is just doing its own job. It is stabilizing the membrane. Be it potassium or be it anything else, calcium is given for membrane stabilization. So it reverses whatever slow conduction has been done by potassium. Calcium will just improve on that conduction. So conduction will get better. Excellent. What about the GI drip? Why do we use it?
Sir, it
This
will decrease
reduces the
potassium level
potassium.
rapidly.
Rapidly? How? Who is
Sir,
the
it
yeah,
sir, insulin
Intracellular.
shifts the potassium intracellularly.
who will do that? Glucose or the
Insulin,
insulin?
insulin
So
Insulin.
why do we say we have to give glucose along?
to
Sir,
prevent hypoglycemia.
hypoglycemia.
Correct. So basically, initially in the protocols, it was IV insulin. So we used to give 10 units IV insulin. Only to counter the hypoglycemia that will happen with it, we give dextrose along with. But you have to understand that this insulin is needed to be given as a bolus. So when we give it in dextrose, it becomes even slower. So that is why sometimes giving insulin dextrose infusion slowly doesn't help us that much. It has to be given as an IV bolus. Along with that, we give esthylene nebulizations, and of course, we give K bind, potassium binding resin. Okay. So this is a medical emergency due to risk of fatal arrhythmias. Um, so what we do is immediate treatment is cardiac membrane stabilization. So IV calcium gluconate, 10 ml, 10% solution to be given over 2 to 5 minutes. Onset is almost instant and duration lasts for 30 to 60 minutes. You repeat the dose if ECG changes persist after 5 to 10 minutes. So usually you need to give around 2 ampules or 20 ml of calcium gluconate. It does not lower potassium, only stabilizes the cardiac membrane. So that means once you have given the calcium, you have to make sure that you've given hypokalemia measures also, that you need to decrease the potassium levels. This is the number one management. Number two is to shift the potassium into the cells. So the goal is temporarily lowering the serum potassium levels by driving potassium intracellularly. Who does that? IV insulin plus glucose. Regular insulin 10 units IV bolus, followed by 25 to 50 ml of 50% dextrose IV to prevent hypoglycemia. The onset takes around 15 to 30 minutes, lasts for a good 4 to 6 hours. It gives you enough time. Let us say you did everything and still the potassium is 8.4. What will you do?
Hemodialysis.
Wonderful. Then you do a
So
hemodialysis.
why not Lasix? First, we will try with furosemide.
The patient has AKI, no? What is the role of diuretics in AKI? Generally, I mean,
So it can be used for hypervolemia.
only. It is only. So diuretics only worsen AKI. So I'm not talking of the regular practice that we do, dear. I also do the same. You also do the same. We all give Lasix. But the thing is, for examination purpose, you have to understand that diuretics they worsen the AKI. Okay? So we have to keep in mind that there is a patient who is unable to pass urine. How are diuretics going to help in that patient for potassium? Claire? Yes or no? Along with that, we give nebulized beta 2 agonist, that is 10 to 20 milligrams via nebulizer over 10 to 15 minutes. Onset is a little slow, 30 minutes. But then, if the patient has already a history of ventricular fibrillation, then you need to be very, very cautious. In fact, giving IV soda bicarb is important because renal failure is there and acidosis worsens hyperkalemia. So you need to give 50 milliequivalents of IV over 5 minutes. That's bolus. Limited efficacy unless metabolic acidosis is present. Now, removing potassium from the body. If the urine is there, see, if adequate renal function, then give loop diuretics. Or else you use the enteral pathway, that is cation exchange resin, like sodium polystyrene sulfonate, slow onset, and then dialysis is the best and fastest method in end-stage renal disease, severe hyperkalemia or refractory cases, indicated if potassium is more than 6.5 and or with life-threatening ECG changes. So you need to have a continuous ECG monitoring, serial potassium every few hours, monitor glucose. Why? Because we are giving insulin, identifying and treating underlying cause, for example, renal failure, medications like ACE inhibitors or spironolactone, you need to stop them immediately. Is that clear about hyperkalemia? And
Yes.
of course, ECG changes. Okay. Now we move on to a CT chest station where you see a 50-year-old post-operative patient who has sudden onset dyspnea and hypotension. We did a CT pulmonary angiogram and this is what we found. Can you see something here? This is the cardiac shadow. This is the right ventricle and this is the pulmonary artery on the left side. This is the pulmonary artery on the right side. So what do you see?
Bilateral
Right
pulmonary
sided
embolism.
pulmonary artery showing a filling defect in the right pulmonary arteries, suggestive of pulmonary embolism.
And about the left side also you see one here.
There's also a filling defect on the left, both
Yeah, there is another filling
left
defect.
branches.
So there is another one. So we have two defects on both sides. So what is the diagnosis? So the diagnosis is pulmonary embolism.
Embolism.
I would
And
not
it's like
say
there's also some pulmonary infarct also. What
I can't say for sure, but yeah,
this okay.
yeah, you can, yeah, you see some high intensity consolidations, but yeah. So basically, it is pulmonary embolism with probably pulmonary infarction. So how would you treat this patient? What are the guidelines? How would you treat this patient or manage this patient? So ABC is all done. Let us move forward.
The
Okay,
patient
If
has
patient is
hypotension,
if the
then
patient is hemodynamically stable, then
Yeah.
there will be no indication for thrombolysis.
Wonderful.
Rather, just start therapeutic anticoagulation.
Yes. So if it is a massive or submassive pulmonary embolism, then you have to immediately do something or else the patient will die. So thrombolysis is the only treatment. If the patient does not have a massive or a submassive PE, I mean low load, then definitely only therapeutic anticoagulation is the treatment. So there are filling defects in both the main pulmonary arteries. There is bilateral pulmonary embolism. This is a life-threatening emergency, suggesting high-risk PE. I would not call it massive unless the blood pressure is mentioned. That shock is there. If associated with hemodynamic compromise, immediately, if you have to do something, give heparin immediately. Why? Because that would set in the ground for thinning of the thrombus load. Immediately, this is what you have to do. So IV bolus equal to the body weight. So whatever body weight is there, you give those milligrams. Maybe if it is a 60 kg man, give them 60 milligrams of a low molecular weight heparin. If it is 80 kgs, give 80 milligrams. Allows rapid reversal if thrombolysis or anything is needed. Start immediately unless contraindicated. So heparin is enoxaparin is good for stable patients. In patients where renal dysfunction or renal failure is there you would use unfractionated heparin. But if the patient has hypotension, BP of less than 90, and signs of right heart strain that is on an echocardiogram, you would use TPA, that is thrombolysis, massive PE. You would thrombolize them with 100 milligrams, 10 mg IV bolus plus 90 mg IV over 2 hours. If you have not yet given anticoagulant, then you give anticoagulant afterwards. Rapid clot dissolution and improves survival in high risk PE. I don't know how many patients you also must have saved using TPA. Supportive care, of course, oxygen IV fluids. Judicious IV fluids are to be given because this is classified under acute lung injuries. So there are chances that if you overload the patient may go into pulmonary edema of fluid overload. Definitive diagnosis requires CT pulmonary angiography, which is a gold standard. However, if the patient is undergoing CPR or something like that, the patient has crashed, then you can just do probably an echo and see if there is a thrombus you can see in the right ventricle. I don't know if I have that echo with me. I used to have so many echo videos, but then they are in my mobile phone. You can actually see thrombus hanging in the pulmonary artery and into the right ventricle. And then while doing CPR, so you can actually thrombolize the patient with 50% of the dose. And then once the circulation sets in, get a CT pulmonary angiogram done. And if the thrombus load is still there, give another 50% of the dose of TPA. Further interventions, surgical or catheter-directed thrombectomy, may be considered in selective cases. What is the role of IV filter, IVC filter in these patients? Anyone?
If
It's
patient
only
is
used in cases of recurrent DVT.
So it is not indicated anymore because the IVC filters themselves get blocked and cause DVT, because then they also become DVT. But if the patient has an ICH and is operated or not even operated, the ICH is there, and in neuro ICU, the patient develops a DVT with pulmonary embolism, or the pulmonary embolism has not happened, but DVT has happened, that is the only selective case where you would put an IVC filter. And that too, you will remove it within few weeks. Because if you don't do that, it will get thrombosed like a DVT. So that is the only one indication. A patient who has had an IV. In fact, even aneurysm clipping, a patient who has had a SAH with aneurysm and post-coiling or post-clipping patient develops a DVT, even in those cases on 11th day, you can start with anticoagulant and you may not require a DVT, may not require a IVC filter. Okay. So for IVC filter, the only contraindication is a ongoing intracerebral hemorrhage, or you have operated and surgical site is there in the brain and the patient has developed a DVT. All right. We ready for the next station? We have a 65-year-old man admitted to the ICU with ongoing chest pain and shortness of breath. History reveals he had a posterior inferior STEMI 3 days ago managed conservatively. Now he's tachypnic, he's hypotensive, the BP is 80/50. What is the difference between hypotension and shock?
In shock, there is obvious signs of end organ hypoperfusion, such as cold, clammy extremities, elevated lactates rates.
Yeah, so any biochemical marker, it is lactates. So lactates are increased. Okay. So this patient is hypotensive tachypnic with oxygen saturation of 85% on 15-liter non-rebreathing mask. Chest has bibasilar crackles and there is a loud pansystolic murmur at apex radiating to axilla. You do vital check, and what you find out is heart rate of 120, tachycardia, BP of 80/50, hypotension, saturation 85, one rebreather at 15 liter, temperature 36.5. So 34 is the respiratory rate tachypnea. ECG shows sinus tachy with Q waves in 2-3 AVF. He has a history of posterior wall STEMI 3 days back. Okay, we've done an ABG also. So what do you see in the ABG? In ABG, you see 7.29 pH, PO2 of only 60 on 15-liter rebreathing mask, which literally gives 90% FiO2. So this patient has only 60 mm. PSO2 30, bicarbs 18, lactates are now rising 4.5. So this patient is in cardiogenic
Shock.
shock. Okay. So this patient has cardiogenic shock secondary to
MR.
Secondary to MI.
secondary to one option.
Mitral regurgitation.
One
Mitral.
differential MI.
With mitral valve
Yeah, VSR.
incontinence.
So with this thought, we got an echocardiography done. We see there is a hyperdynamic left ventricle with a flail posterior mitral leaflet. Severe MR is there. There is pulmonary hypertension. The PA pressures were 85 millimeters of mercury. Imagine systolic BP was 80 and pulmonary systolic pressure was 85. This patient was bound to die, but then did not die. No pericardial effusion. What is the likely diagnosis? I've created few MCQs for you. What is the most likely diagnosis?
Papillary muscle rupture with acute MR.
All right. So which echocardiography finding is most specific for this diagnosis?
Flail mitral leaflet with MR.
Great. So what is the definitive treatment?
Urgent surgical management.
Okay. So definitive means end. Okay. What is the best temporary stabilization strategy before surgery?
Inotropes plus afterload reduction plus IABP.
Correct. Plus minus ECMO.
VA.
Which coronary artery is most commonly implicated in this complication?
Circumflex left.
Left main.
Okay, so let's discuss. All right. So the first is B, that is acute MR. So sudden decompensation, systolic murmur, hypoxia, flail leaflet, classic of papillary muscle rupture post MI. When does this happen? This complication, this is a mechanical complication. Usually
2 to 3
happens.
days.
The second or
Yeah.
third.
Yeah. So third begins on third day, and then up to 5 days it can happen. So then flail mitral leaflet with eccentric MR jet is the echo finding. Correct answer for third is surgery definitive. Medical therapy is only temporizing measure, which is inotropes, afterload reduction, and IABP. So this is the LV and this is the aorta. So basically this is a leaking valve. So we put an IABP here so that the blood tends to go into aorta and not go into the left atrium. So we are trying to decongest the left ventricle with the help of IABP. We are supporting the LV, that is also there, but here we are just trying to decrease the systemic vascular resistance with the help of IABP. So this question has been asked many times. When the patient is in heart failure because of the poor left ventricle function, and the IABP is supporting the left ventricle as an assist device. But when it is being used for VSR and MR, it is being used for decreasing systemic vascular resistance. So the role is different in both the cases. It is the RCA because the posteromedial papillary muscle is supplied only by the RCA or left circumflex in left dominant circulation. How do you define dominant circulation? Anyone? How do you define dominant circulation? So whichever
The
whichever
posterior
artery
descending artery when
gives,
branches from left
yeah,
circumflex.
whichever artery gives rise to posterior descending artery is determines the dominance of the circulation, making it vulnerable to infarction. So it is usually the RCA which causes this. So flail posterior mitral leaflet with severe acute MR is the diagnosis. Two immediate interventions because it is a surgical emergency. It is not a medical emergency, but everything falls on the critical care to immediately stabilize such a patient. So you do hemodynamic stabilization using IV vasodilators. You don't worry about the blood pressure. Blood pressure is already 80. Unless you dilate this patient is not going to get any blood flowing into aorta. Make it very clear. Many times students tell me, sir, what will happen? We would just increase nitrates and the BP will go down. BP is already down. You give nitrates or nitroprusside immediately along with reading the IABP and trying to get blood flow into aorta. Unless you get the blood flow into aorta, no, the inotropes are only going to make the things worse. The vasopressors are going to make it even worse. Norepinephrine, vasopressin, everything is going to make it worse. Why? Because they will increase the SVR and the blood is anyways flowing back into the mitral area. So it will keep flowing back. So IV vasodilators to reduce the LV pressure and MR volume, inotropes, dobutamine. See, you don't see any norepinephrine here. Improve forward flow and cardiac output using IABP or ECMO if available to improve cardiac perfusion and reduce afterload. Urgent cardiac surgery referral. You don't have much time. Emergency mitral valve repair or replacement is definitive. Delay leads to worsening pulmonary edema, shock, and high mortality, very high mortality. Avoid excessive fluids. The moment you give fluids to resuscitate this patient to get some BP up, this patient is going to get down the hill. Oxygenation and ventilatory support are essential. Usually put them on that. Papillary muscle rupture, acute severe MR leading to cardiogenic shock, usually in inferior wall MI, RCA territory, typically 2 to 7 days post MI. Echo is diagnostic, surgery is definitive. Temporizing with afterload reduction, inotropes and IAVP if available, and ECMO if available. All right. Okay. We have a patient who is a 78-year-old male brought to the emergency department after a syncope episode at home. His wife reports that he suddenly felt unconscious while sitting and was unresponsive for 30 seconds. No seizure activity, no urinary incontinence. He has history of hypertension and is diabetic. At presentation, patient is awake but complains of lightheadedness and fatigue. Heart rate is 32, BP is 80/50, respiratory rate 22, and saturation is also 92. On room air temperature is 36.8, GCS is conscious. Okay, give me the diagnosis. Okay, give me the diagnosis. What do you have here? The heart rate is
The
only 36.
HQRS is not, it's not, PR interval is not constant before every.
This is complete heart block with complete AV
Complete heart block.
dissociation. This is complete heart block. Total AV dysynchrony is there. So this patient has a complete heart block. Usually, I mean, you don't see any synchronization between them. So this is complete heart block, that is third degree AV blocks. There are P waves present and regular, not related to QRS. Ventricular rate is 30 per minute, broad QRS complexes, no AV conduction, atria ventricular beating independently of each other. All right. So do your ABCs, then establish an IVC access. What you need to do is immediately do a temporary pacing. So transcutaneous pacing can be done. It's a jacket-like situation where you use external defibrillatory pacing mode. Not everybody has it, but if you can, place pads in the anterior-posterior position, one in the back, one in the anterior. Set rate to 860 to 70. There's a lot of discomfort because it keeps on firing through the skin. So you will need sedation and analgesia. Atropine, you can give 0.5 milligrams every maximum 3 milligrams every 3 to 5 minutes as per the algorithm. It usually does not help in complete heart block. With a lower block may work only if the block is at the AV nodal. And yes, while you have done the immediate temporary pacing with the jacket or the transcutaneous pacing, immediately prepare for transvenous pacing via temporary transvenous pacing via central venous access. So now this is a degenerative complete heart block. Supportive care would need oxygen therapy, reversing any electrolyte imbalances, any ischemia, do a RCA. If you do a coronary angiography, find RCA blocked, open it up. Drug toxicity like beta blockers, digoxin, calcium channel blockers, TCAs in elderlies, many times they are on antidepressants, so they can also cause that. Definitive treatment is permanent pacemaker. So this is how you will get these questions. So this was the last station. Any questions you can ask. So we are done with it. Stop sharing. Yeah. Any questions?
If any aspirant have any questions, they may ask now.
Okay, if there are no questions, then we may call it off. Thank you very much. All the best, everyone. Prepare hard, do well in the exam. Thank you. Bye-bye.
Thank you, sir.
Thank you, sir.
Bye-bye.
Thank you.
Thank you, everyone.